laboratory-based methods to close the detection gap. Thank you very much indeed for joining us. My name is Rita Rodo and I'm the Senior Advisor with the Union. This webinar has been organized by the Union's Sub-Saharan Africa Child and Adolescent TB Center of Excellence, in collaboration with the Division of Global HIV and TB of the Centers for Disease Control and Prevention, CDC US. I will today serve together with the others, including Drs. Barreira and Dr. Mutemba, as facilitators of this webinar. Before coming or proceeding, I would like to share a few housekeeping issues. You may have joined the presentation using your computer's speaker system by default. If you would prefer to join over telephone, just select phone call in the audio pane and the dial-in information will be displayed. Please ensure that you are on mute during the presentations and when you aren't speaking. There will be opportunities for questions at the end of the presentations, and we will save all questions and discussions to the end of the session. You will also have the opportunity to submit text questions to today's presenters by typing your questions into the chat panel. You may send in your questions at any time during the presentations. We will then collect them and address them during the question and answer session at the end. For the last question and answer session, we will open the floor to allow discussion on the points raised by today's speakers, as well as to share the Center of Excellence, country experiences and perspectives. So once more, welcome to today's webinar and a special warm welcome to our chairpersons, presenters, and country representatives from the COE member countries. Colleagues, it's now my pleasure to introduce you to today's chairpeople, Dr. Draudia Barreira and Dr. Grimenia Mbate Mutemba. Dr. Barreira is
Sorry, Brittany, I think I lost you at the end, just at the start of the presentation of the chair. I don't know if you finished because I lost all the connection with the sound.
Hello, Jumpo here. Let me complete this section that Rita was taking on, and then I'll hand over to the chairs. She was at the point where she was introducing Dr. Draudia Barreira. Dr. Barreira is a senior technical manager on the strategy team at Unitaid. He has worked for two decades in epidemiology, HIV/AIDS, tuberculosis, and public health. Before joining Unitaid in 2015, he headed the TB program in Brazil's Ministry of Health. Then our second chairperson is Dr. Grimenia Mutemba. Dr. Grimenia Mutemba is a pediatrician and a PhD fellow with clinical experience in TB/HIV. She has served as a child TB specialist in Maputo City for several years. Currently, she is the child TB focal point for the National TB program in Mozambique, but she also coordinates the Childhood TB Technical Working Group. Welcome to both of you, and thank you so much for sharing today's webinar. Over to you, Dr. Barreira.
Thank you, John Paul. Thank you, Brittany, all colleagues from CDC, from the Union. I can see Grania here, and all the organizers for this invitation, and also for the opportunity to participate of this webinar. And welcome to all our distinguished speaker and participant from across the region. Well, I don't need to say to you how challenging is the diagnosis for TB in children, especially young children, leading to a lack of confidence among clinicians in confirming TB for children in non-tertiary health settings. Even gold standard diagnostic methods using high-quality respiratory specimens are likely to confirm just a small portion of TB among children. These challenges highlight the need to ensure evidence-based methods for clinical diagnosis are in use in all levels, while further developing and implementing new tools to optimize bacteriological confirmation in this specific population. This year, WHO is leading a review of guidelines for screening, diagnosing, and treating TB among children. This review includes assessment of screening approaches and clinical scoring algorithms for maximizing the utility of symptom screening, radiography, some of them using artificial intelligence, and physical examination to optimize diagnosis, as well as reviewing the use of minimally invasive specimens for TB diagnosis in multiple platforms. As you know, for the first time in many years, we have good news and a pipeline of many promising tools to increase TB detection among children. Unitaid is funding some projects in the region, putting together new diagnostic tools, new clinical algorithms, using new samples as the stool or nasopharyngeal aspirate to improve TB detection among children. I will take this opportunity to announce firsthand that the next week, 24 March, Unitaid will launch a new call for proposal addressing TB diagnostics, which will include children, of course. It's for TB sensitive. But I can't give you any more details than this right now, but I'm happy to discuss later. Sorry if I spent too much in my introduction at this webinar, but I think it's important to share good news when we have the opportunity to do this. And talking about good news, this webinar will review the diagnostic care cascade for children and the role of clinical decision-making and laboratory-based methods in reaching a diagnosis and initiating treatment in children. To introduce the first speaker and to make a few opening remarks, I pass the floor to my colleague, Grimania. Over.
Thank you, Dr. Barreira. I'm very pleased to be here today in this important webinar. And I would like to also thank the union for the invitation. In today's webinar, we will review the importance of clinical decision-making in reaching the TB diagnosis in children, while exploring ways to maximize clinical information utility in reducing time to diagnosis. We will next hear from colleagues of the CDC and USAID regarding best practice in laboratory-based diagnosis, as well as the state of the evidence of urine and stool-based diagnosis methods. To close out our presentation, our colleagues from Zambia will share early experience piloting the TNCV stool-based processes method for diagnosis TB in children and discuss plan to roll out method nationwide. After the presentation, we will have question and answers and can discuss and share experience and perspective from all Center of Excellence member countries joining us today. My pleasure to present our first speaker, Dr. Anna Mandalakas. Anna is a professor of Pediatric and Tropical Medicine at the Baylor College of Medicine, where she serves as a chief of the section of Global and Immigrant Health and directs the Global Tuberculosis Program of Texas Children's Hospital. For nearly 3 decades, her translational research has focused on the identification of Mycobacterium tuberculosis infection, TB diagnosis, and prevention of TB disease in children living in both high and low border countries. Dr. Anna Mandalakas will present on clinical diagnosis, the good, the bad, and the ugly. Dr. Anna, please, you have the floor.
Thank you, everybody. I'm just going to take a second here and set up the screen share. Well, it's a pleasure to be here with you all today, and really happy to be here, and just want to check to make sure that the screen share is going okay and everyone can see the slides well and the screen is full.
Yes, Anna, the screen's showing well, thank you.
It's good. Okay, great. So during this talk today, we are going to review the role of clinical evaluation and diagnosis for TB among children and highlight recent developments to enhance the utility of clinical information for more rapid and timely diagnosis. So it's estimated that 7.5 million children are infected with Mycobacterium tuberculosis each year. And most recent data demonstrates that 1.2 million, or about 16% of those children, developed TB in 2019. Of those 230,000, about 20% lost their battle to TB. New data also has some good news for us that we can treat children well for TB. And data from 19 of the 30 TB high-burden countries demonstrates an overall success rate of 85%, ranging from 97 to 73%. What about the 230,000 children who died from TB? This evidence suggests that about 80% of these children are less than 5 years of age, and about 17% are living with HIV. But most important, this modeling work actually demonstrated that greater than 96% of all children who die from TB die without treatment. And this is some of the bad information that I'm going to share today. Recent evidence also shows us that part of the problem is this persistent case detection gap. And you can see here that 25% of adult cases are missed. If we look at pediatric cases, 56% are missed. And if we look at children under 5 years of age, it simply gets ugly, with 65% of all cases being missed. So why is this going on? Well, part of the reason is that we have traditionally relied on passive case finding, which means that a mom brings her child to the clinic and the astute clinician says, these symptoms sound like TB. But this makes us dependent on the mother showing up at the clinic. Fortunately, in the recent past, we've had a lot more active case finding activities going on. And this is a picture of a team in Eswatini in combination of Baylor and the National TB Program, instituting community-wide household contact tracing. So going to the home of a newly diagnosed TB case, asking household members if they have symptoms, collecting sputums from those symptomatic members, and then taking those sputum specimens and linking them to expert machines in 3 of the 4 provinces of Eswatini. In the first year of this project, we noted a 32% increase in case detection of bacteriologically confirmed TB. And so this is a really nice example of the potential impact of screening and diagnosis. And I want to talk a little bit about the difference between screening and diagnosis. And this is a figure showing the patient-initiated pathway. So you start with a patient who's exposed, perhaps infected, develops TB, maybe recognizes their symptoms, presents to allow passive case finding to happen, hopefully is referred for evaluation and is then diagnosed. But at all points along the way of this pathway are opportunities for screening, opportunities for early diagnosis, which means improved outcomes for children with TB. So this is the first question I have for you today, and we're actually not going to use the polling feature, but the question is, if you have a test with a sensitivity and a specificity equal to 95%, is that a good test? The choices are yes, no, and maybe. And so I'm going to just give you all a little chance to think about what that answer is. Okay, so the answer to this question is actually maybe. Sensitivity and specificity are inherent properties of the test, but the positive predictive value of a test is dependent on the prevalence of the target condition in the population. So if you use this test in a population with a 90% prevalence, your positive predictive value is going to be 99%, meaning that 1% of your positives are false positives. Use that exact same test in a population with a prevalence of 1%. 85% of your positives are going to be false positives. So if we then take this information and think about it along the patient-initiated pathway, we realize that as patients traverse this pathway, the prevalence of disease increases. So therefore, the positive predictive value of the same test will vary along this pathway. And here are two examples of systematic reviews that my team did for the WHO, both looking at the performance of expert MTB-RIF. The first one looking at the utility of this in diagnosis. So this is a collection of studies that were done at this point on the pathway. We assumed a prevalence of 10% in those population. The positive predictive value is 87% when used here. Now, if we look at expert MTB-RIF for screening in an exposed population, this is one study that we found. The prevalence was 0.7%. The positive predictive value was 50%. All right, so now I want to bring together these concepts with respect to what happens in the management and treatment of a child with TB. Now, a well-trained seasoned clinician, when they look at a patient in front of them, does a pretty good job of medical decision-making in their mind, determining the probability of diagnosis. So here are three examples of children. So the first child here is an 8-year-old, healthy, growing well, smiling and happy, asymptomatic, and the mom says, well, her uncle visited 5 years ago and was just diagnosed with TB. Do we need to do anything? Most physicians would not order any test, and they would watch this child. Now let's move to this 4-year-old whose uncle visited last year and was just diagnosed with tuberculosis, smear negative, but was with them for a month. And the mom says that the child is a little bit less active and all she wants to do is eat chocolate. Well, at this point, the physician has probably crossed their threshold for doing a test. And perhaps obtaining a test in this child might change what their treatment would be. Now we move to the third child. This is a 4-month-old baby sleeping in the same bed as her mom, who has 3+ smear positive TB. The child's cranky, not eating, losing weight. Most clinicians would simply treat this child, and you would have crossed what we refer to as the treatment threshold. All right, so what this example illustrates is a lot of the information that we use to help us with clinical diagnosis. The first is age, and we know if a child is younger, they're more likely to develop TB after diagnosis. A child less than 1 year of age will have a 50% chance of progressing to disease. 15% of these children will develop disseminated life-threatening disease. Time since infection. Since the 1940s, we've known that about 95% of children, if they're going to develop disease, will do so within the first 2 years following exposure. So when you do your history with the child, you focus on contact history and symptoms in the child. For contact history, you need to understand when the contact happened, how intense it was, who was the index case, do they sleep with the child, how much interaction do they have with the child, are there more people coughing at home, are there more TB cases, is that home saturated with TB without windows such that the child's very likely to have been infected. Symptoms in the child. Does this child have a cough, a persistent, unremitting cough? Does the parent think that they're failing in their growth? Do they have the growth card available? Have they noticed fever? Has playfulness decreased? Do they say this child is less active? Anything else bothering them? So this is a recent study that was completed that is actually in press, and it is a nested study within a larger household context study. And it's a matched case control study in Pakistan, where they used a score with 10 questions. And if you answer yes to a single question, you get 1 more point. And they showed that for every additional question answered yes, the odds of TB in the child increased by 44%. And it's just a beautiful example of how exposure history can help diagnose TB in a resource-limited setting. What about physical exam? Well, the vital signs are generally normal, as is the pulmonary exam. Occasionally, the exam might have some features, for instance, recurrent cough or wheeze responsive to bronchodilators, which would suggest another diagnosis like reactive airway disease. By far, on physical exam, the most important thing is growth. And here is a picture of classic flattening of the growth curve, and here is crossing twin tails. And when we see these things in a child, it raises the suspicion of tuberculosis. All right, so now it's actually a polling question that Grania is going to help us with. So before we go to the poll, what I want to, or we can go to the poll and you guys can vote, but the good here is that if we combine data from our history and our physical exam, it improves the positive predictive value of our clinical diagnosis. So if you can pick 3 pieces of information from this list to help you make the diagnosis of TB in children, what would be those 3 things? Okay, now you can all vote.
And those of you who are co-hosts, I'm afraid to say you're not able to vote, just in case you're wondering, but we have good engagement. Thank you, everybody.
All right, I'm going to end the poll. And let's see, I'm going to move this here for you all to see. Unremitting cough, failure to thrive were picked very high, and also decreased playfulness. You guys are very, very good. So the classic triad of persistent unremitting cough, documented failure to thrive, and decreased playfulness has a positive predictive value of 82% in children older than 3 years of age without HIV infection, 90% in children less than 3 years of age and without HIV infection. So it really demonstrates how good a good history and physical exam can predict TB in children. What about imaging? Well, radiographs have been the historical cornerstone of diagnosis, despite having a sensitivity of only 39%. This means that a normal chest X-ray does not rule out TB. Now, of course, if you're fortunate to have hilar lymphadenopathy and see this classic donut sign on a lateral film, sensitivity increases to 67%. And actually, CT is more accurate than chest X-ray for lymphadenopathy. And the CT, ultrasound, and MRIs have increasing roles in diagnosis for children, but they're very limited because of limited access and dependent on the setting. There is going to be some new guidelines released very soon by WHO, where they actually looked at systematic screening for tuberculosis. This evidence actually demonstrated that chest X-ray is a sensitive screening tool with a role for early detection and potential to reduce population burden of TB. They also compared the diagnostic accuracy of computer-aided detection, CAD, to human reading. And although CAD had substantial variation based on different settings, the diagnostic accuracy and performance of CAD was similar to human reading. So these guidelines are actually going to support community-wide systematic screening using sensitive tools such as chest X-ray, followed by an accurate diagnostic test, even in populations with a prevalence lower than 1%. And importantly, they're actually going to allow CAD to be an alternative to human reader interpretation of plain digital films for screening and triage purposes for pulmonary TB in adults. There's actually almost no data for CAD in children. So these are the current WHO guidelines for management of tuberculosis in children, and they basically say that the diagnosis of TB in children relies on thorough assessment of all the evidence derived from a careful history of exposure, clinical exam, and relevant investigations. We're really excited that these guidelines are going to be updated this year, and they should be released by the end of the year. We anticipate that the guidelines will be much more detailed. And in addition to these guidelines, there will be an accompanying operational handbook with practical how-to guidance on many, many topics, including those without evidence-based recommendations. So for the rest of this talk, I'm just going to highlight a little bit of new evidence that will be informing these guidelines. Okay, so we're going back to this classic triad. How did it work in children living with HIV? Not very good. The positive predictive value was 62%. So Olivier Marcy and his group in Bordeaux actually developed a treatment decision score for HIV-associated child TB. They looked at over 400 cases of presumed TB in children coming from Burkina Faso, Cambodia, Cameroon, and Vietnam. And they developed 4 models. The models had many, many clinical symptoms, and the first model included also abdominal lymph nodes assessed on ultrasound and quantiferon. The second model excluded quantiferon, third model excluded abdominal ultrasound, fourth model excluded both quantiferon and abdominal ultrasound. And the first 3 models had equal discriminative ability. So they went on to develop this treatment algorithm using the second model, aiming to have a 90% sensitivity. They were able to achieve 80% sensitivity. And the model looks like this. This is the model. You have a child living with HIV with one of these 4 symptoms. If they have a history of contact with the patient with TB, their score is immediately 118. If the score is greater than 100, you treat. If they have no contact, you evaluate these symptoms in more detail and try to increase their score. If the score goes above 100, you treat. If the score is still below 100, at this juncture, you can either get a chest X-ray, expert, or ultrasound to try to again increase the score above 100 and treat. If the score is not above 100 at this point, you have a pretty good sense it's not TB, and you treat for another condition and continue to reassess. Now, this paper was just pre-printed this past month, and Gunasekara actually worked with folks from Desmond Tutu in Western Cape, and he looked at almost 500 children with presumed TB. He developed 2 models. The first model relied just on clinical symptoms, and it's this red line here. And this shows us that it captured about 71% of cases. The second model included chest X-ray and expert, and it's this blue line here in the ROC curve, and it captured 89% of cases. So then he used the blue model to go on and develop his algorithm. And very similar to Olivier Marcy, this model has a sensitivity of 90%. You have a child here without HIV who has one of these 3 symptoms. If they have exposure, you immediately treat. If not, you actually do a more detailed clinical evaluation, aiming to get the score above 100. If the score is above 100, you treat. If the score remains below 100, you do a chest X-ray. If you see pulmonary TB, you treat. If not, you do expert. And if X was positive, you treat. If not, unlikely for this child to have TB, and you actually treat for another condition or reassess. So the last bit of evidence I want to share with you is some work from our team in Mbeya, Tanzania, which is a real life retrospective analysis of what happened to children in this clinical setting between 2013 and 2016 who had presumed TB. So as you see, first thing is, of these 455 children, only 70% gave a first sputum specimen, which is actually pretty good. Following national guidelines, that specimen was tested by expert and smear. Of these children, 90% gave a second specimen, which were able to give a second specimen, which went on for culture. What you can see is the positivity of these tests is pretty low. 3% per expert, 2% for smear, 5.5% for culture. What we did was then we went on to look at how these tests perform against a clinical reference standard, which was someone said this child needed to be treated for TB. And as you can see, this, regardless of if they were inpatient or outpatient or living with HIV or free of HIV, the sensitivity of these exams were very low, ranging from 4% to 22%, meaning that it's very, that in most of the children who somebody diagnoses with TB and starts treatment, they will not have a positive exam. So just my final take-home messages for you today are that nothing replaces a robust history and strong clinical skills to support medical decision-making that creates a context within which to accurately interpret tests. And this is actually really good. And we need to support clinicians to confidently diagnose TB clinically by prioritizing clinical training, skills building, and mentorship for clinicians. Now, although TB diagnostics are rapidly evolving, one of the unfortunate things is that health system weaknesses can truncate the impact of these new tests. And we simply need to recognize that the majority of children will be diagnosed clinically until technologies become more sensitive and available at all levels of the health system. And then finally, my most favorite thing to tell students is that a rapid urine pregnancy test performs poorly in men. And this basically means that if you have a really good test, but you use it in the wrong population, the results will be meaningless and it is going to be a waste of precious resources. So I just want to quickly acknowledge colleagues who have actually helped with some slides and also over the years to develop concepts and provide experience that went into this talk. I want to specifically highlight colleagues from the WHO who gave some of those slides and also some additional slides that are available at the end of my thank you slide for you to look at later. And just finally, I want to thank all of you for listening and for your interest in child TB.
Thank you, Dr. Pandalakas. Very good and clear presentation. I really like especially the title of your presentation as well. As we are a little bit behind the schedule, I will recommend our attendants to keep the questions for the end, the Q&A session, but you can put your comments or question on the chat box at any time. Our next speakers, Dr. Patricia Hall and Dr. Charlotte Coving, will present together. Dr. Patricia Hall is the lead of TB and clinical monitoring team, which sits within CDC's Division of Global HIV and TB International Laboratory Branch. She also managed the WHO Supranational TB Reference Laboratory and serves as a vice chair of the Stop TB Partnership Global Laboratory Initiative. Today, she will be joined by Dr. Charlotte Coving, who serves as Senior TB Technical Advisor for USAID Global TB Program, focusing on pediatric TB. Before joining USAID in 2012, Charlotte worked with PET and EGPEF, supporting TB HIV programs in high-burden countries. Dr. Patricia Hall and Dr. Charlotte Coving will presenting laboratory-based diagnosis, traditional and novel approaches for confirming TB in children. Thanks you both for joining us today. The floor is yours.
Thank you so much. And thank you to the organizers and the chairpersons for inviting me here today. Just checking, can you hear my audio okay and see the slides?
Yes, can do both. Thank you.
Yeah.
Wonderful, thank you. Okay, so following on to Anna's presentation, I think she did a wonderful job highlighting the need for advances in laboratory-based pediatric diagnosis. And we're going to talk through some of those today, along with the performance of some existing technologies to support bacteriological confirmation of pediatric TB. So due to poor access to TB diagnostic, treatment, and reporting services, 70% of the global 5-year target for pediatric diagnosis and treatment remained unmet as of 2019, with only 1 of 3.5 million targeted children receiving services. And only 8% of all new cases in 2019 were reported in children less than 15. TB services must therefore incorporate decentralized, innovative, and as Anna said, more sensitive, child-friendly approaches to end pediatric TB. A recent Kenya study analyzed diagnostic progress for over 23,000 pediatric patients over 2 years, helped to highlight the specific gap in pediatric access to TB diagnostic services. This evaluation found that despite more than 50% of clients presenting with signs and symptoms of TB, the vast majority, or 85.9%, did not receive any diagnostic testing, and less than 2% received bacteriologic testing of any kind. Recent advances in laboratory-based diagnosis, some of which we'll discuss today, are therefore focused on delivering simpler, safer, more sensitive ways to collect and test pediatric samples to improve service utilization and impact. So how should children be bacteriologically tested for TB? According to the latest WHO guidance, all children should receive an initial molecular WHO recommended diagnostics, or MWRD, shown here in green. In addition, HIV positive children with advanced HIV disease, defined as those 5 or greater with CD4 or clinical evidence of advanced HIV, and all HIV positive children under 5, should receive a rapid lateral flow LAM test in parallel to molecular diagnostic testing. This is highlighted in the blue pathways. We'll touch on that a bit later, but since all children with presumptive TB are recommended to receive at least 1 MWRD, which are recommended for pediatric testing. Those recommended by WHO are shown here and include the near point of care Expert MTB-RIF and Expert MTB-RIF Ultra, and the point of care TrueNat, MTB, and MTB Plus tests. Note that TB LAMP, which some of you may have heard of, is not WHO recommended for use with pediatric specimens due to its decreased sensitivity in possibacillary samples compared to the Expert and TrueNat-based tests. Compared with culture positivity as a reference standard, data demonstrate that while no rapid molecular assay is perfect, Expert Ultra has higher sensitivity, albeit with a slightly decreased specificity, which was covered nicely by Anna, across sample types for detection of TB in children. While pediatric performance data for the TrueNat assays is limited, with the WHO recommendation being based on data extrapolated from adults, a similar trend is in increased MTB plus sensitivity over the MTB test is expected. So which sample types are recommended for use with these tests? As of last year, based on available performance data, WHO recommends sputum for use with all of these tests, and gastric aspirates, shown in orange, for use with Expert MTB-RIF and Ultra. And additionally, the minimally invasive nasopharyngeal aspirates, or NPAs, as well as stool, both highlighted here in blue-green, for Expert MTB-RIF testing. Importantly, the lack of recommendation for these sample types, specifically the NPAs and the stools, with the other tests does not signify that they do not or will not perform well on the other assays. Instead, it highlights a lack of data to support their recommendations, underscoring that further operational research is urgently needed to inform evidence-based global policy on their use, and we'll hear more about that today. Lastly, a greater array of specimen types is under investigation, including oral swabs, nasopharyngeal swabs, volatile organic compounds detected through breath, and more. But for now, let's take a look at what we have. How do the WHO recommended specimen types perform? Data in the table at the top demonstrate higher pooled sensitivities for gastric aspirate and sputum specimens than those for stool and MPA. However, values for stool and MPA are not insignificant against culture positivity, particularly given the ease with which stool may be collected and the less invasive nature of MPA collection over the gastric aspirates. Similarly, data in this chart for 31 Kenyan children demonstrate that more children received positive test results, as shown on the y-axis, when more than one sample of any specimen type was collected, depicted by the squares in the figure. And while positive detection was greatest with gastric aspirates, outlined in blue-green, NPA closely followed, outperforming induced sputum in this study. These differences in findings shown here highlight known variability across studies on this topic, but regardless demonstrate that minimally invasive NPAs may have increased utility among certain patient populations and/or settings, and that stool and urine, outlined here in the red box, while not performing as well as the traditional specimens, still contributed to the positive detection of MTB for these children. But there's no need to choose just one. Combinations of sample types are consistently shown to increase detection of MTB across test types analyzed, even combinations of the less invasive specimen types, as shown in the boxed flowchart on the left, which highlights combinations of NPA, denoted as N, and stool as S, alongside their respective yields, shown as numbers. In fact, findings from the same Kenyan cohort demonstrate that expert MTB testing on 2 NPAs or on 1 NPA paired with a stool specimen performed comparably to 2 gastric aspirates or induced sputum specimens. Similarly, a Bangladeshi study last year reported that expert ultra of testing of 1 induced sputum and 1 stool sample increased bacteriological confirmation 15 to 60% compared to testing with each sample on its own. While increases in yield vary, with the graph on the right highlighting that gains shown on the y-axis increase with increasing setting pretest probability or TB burden across the x-axis. Same-day collection of multiple and non-invasive specimens reduces burden on pediatric clients, on their families, and on the health system. So let's take a closer look at stool as a new specimen type that may be additive in these strategies. To use stool for TB testing, it must be collected, of course, homogenized, and processed. I've highlighted the processing step here as it's critical to reduce particulate matter in the sample that could interfere with downstream molecular testing procedures. Previous processing methods required centrifugation of diluted samples and/or filtration with manually assembled devices. However, recent advances have acknowledged the need for simpler, infrastructure-independent methods, and procedures have been developed, 2 of which are shown here. On the left, the TB speed sucrose flotation method requires the sample to be mixed with a sucrose solution, incubated, and then treated with TB expert sample reagent prior to testing. On the right, the KNCV simple one-step or SOS method. The stool sample is mixed directly with TB expert sample reagent, settled, and subsequently tested. Charlotte Colvin from USAID and colleagues from Zambia will speak more on this SOS method today. So what's all the fuss about? How does stool perform? Recent data demonstrated that MTB-RIF testing of pediatric stool samples can yield promising results with pooled sensitivities in a systematic review ranging from 61 to 79% when compared with culture, with the high end of the range reported for children living with HIV. Additionally, stool performance data on expert ultra are just starting to roll in, with the first study published this year reporting a 20% increase in sensitivity over MTB-RIF, albeit with the expected concurrent increase in trace and false positive test results based on the slight decrease in test specificity. Unfortunately, analyses to date have been blunted by variability in study designs, where people collect differing amounts of stool, they test them immediately or they store them for use later, variability in procedures and reference criteria, and in population characteristics. These factors have prevented a systematic review of stool performance among children less than 5, a group that would particularly benefit from the non-invasive nature of this sample type for bacteriologic confirmation of disease. Optimized stool processing and testing is therefore another focus area for operational research and programmatic support being investigated by various organizations, including the TB Speed Research Project, which is focused in the 7 countries shown on the map here and aims to release findings this year on detection, yield, feasibility, safety, and acceptability of decentralized pediatric stool and MPA testing strategies. So now that we've reviewed specimen types and testing approaches, let's see how these are applied in WHO's latest testing algorithms. Last year, WHO released consolidated guidelines and an operational handbook, shown here in green, on TB diagnostic testings for all persons with presumptive TB, outlining recommended specimen types, tests, testing algorithms, as well as decision pathways. And these are inclusive of children, including comments specific to the management of children, interpretation of results, and action throughout. Displayed here is algorithm 1, recommending MWRDs, again, those are the molecular tests we covered, for all, and showing a range of possible test results and their associated decision pathways color-coded into columns. While most pathways are straightforward and apply to clients of any age, pediatric actions are specifically highlighted. So let's take a look at one of those. Green pathway A here highlights the utility of repeat TB expert testing, specifically for children that receive an initial negative result and are in settings with pretest probabilities of 5% or more. In these cases, repeat testing should be conducted on evidence-based specimen types, noting here that stool is an option, as is in PA, at the same testing site and on a fresh specimen, again, highlighting the utility of these easy to collect specimen types if a new specimen is going to be required or if multiples can be collected on the same day. And the second test result is the one that should be used to inform pediatric bacteriologic confirmation. Lastly, as mentioned earlier, children with advanced HIV disease are additionally included in this algorithm and are recommended to receive a urine-based lateral flow LAM test in parallel to their MWRD. This does not replace the rapid molecular testing. LF-LAM testing requires only 60 microliters of urine to be placed on a test strip, incubated for 25 minutes, and result bands read by eye against a manufacturer-provided reference card. This recommendation is again based on extrapolated data from adults, given limited published data in children, highlighting yet another area of operational research that is needed, but also serving as another example of the expanding diagnostic landscape for kids where urine becomes an option for TB testing. Of note, a positive LF-LAM here may trigger treatment initiation in advance of receiving molecular diagnostic test results, of course in combination with that all-important clinical evaluation. This step is circled in red. However, a negative LF-LAM does not rule out TB disease, circled in green, and TB screen positive patient management should instead be based on the molecular diagnostic test results and again, the concurrent clinical evaluation for children. So in summary, advances in pediatric TB testing services are aimed at implementation of simpler, safer options that are closer to pediatric patients and more sensitive. We're currently in a phase where we have expanding diagnostic test and procedural landscapes, expanding and less invasive specimen types, and a lot of different approaches to optimally utilize these are underway. Minimally and non-invasive nasopharyngeal aspirate, stool, and urine specimen types contribute positively currently to increased bacteriological confirmation of pediatric TB, and it's recommended that different settings review their epidemiology, their patient needs and characteristics in order to determine differing approaches that may benefit their patient populations and take into account real-world resource availability. Combinations of these same-day pediatric samples may perform similarly to the previous standard of care, as was seen in the recent Kenya publication. And operational research and strengthened data capture and recording systems are urgently needed to inform evidence-based global policy, such as the upcoming consolidated guidelines on pediatric TB that were mentioned by Anna. Lastly, recent WHO operational guidance does consolidate specimen type and action-based recommendations into one practical resource that does touch on pediatric considerations and actions for interpreting current recommended WHO tests. Lastly, I've included a final slide here with future developments and resources where some upcoming releases are highlighted on the top half of the slide that we can all look forward to. And resources are hyperlinked at the bottom as references for the audience. So thank you so much for your time.
Great, and thank you so much, Patricia, because you've set me up very nicely to talk a little bit about USAID's work in this area. This will not be a very data-heavy presentation. I just want to review some highlights and really leave it to Dr. Zimba from Zambia to provide a more detailed example from the work that he and his colleagues have been doing. So I'm just going to give you a quick summary of USAID experience to date, some background on how we're approaching pediatric TB diagnosis, what we're currently supporting and what we anticipate for the future. So as you all know, we continue to observe gaps in the diagnosis of children with TB, even where countries are on track to meet their UNGA targets, we continue to have a lot of concerns about what I call the quality gap. Notifications are lagging in some USAID supported countries, but we're equally concerned that in some settings, we're seeing a lot of overdiagnosis of TB among children. And when we look at subnational variation within countries, we observe potential under and overdiagnosis. And so rather than really focusing so much on numbers, we're really trying to emphasize high quality patient-centered TB diagnosis for children so that we could address both a potential under and overdiagnosis concern. Next slide, please. So the first thing that we've been doing in this area is in response to requests from missions and our implementing partners, we have developed what we're calling some interim guidelines for pediatric TB diagnosis. They're hot off the presses. They were just finalized about 10 days ago, and I can make them available to this group. This was really prompted by WHO's rapid communication on the use of stool. And because we noticed that a lot of countries where USAID is working were including stool-based expert pilots and scale-up in their Global Fund concept notes. But we also wanted to balance the interest in this new diagnostic approach with the reality of its limitations. And so when we were first doing stakeholder interviews around these guidelines and getting advice, many wise people, some of whom were on this call, said, please, this is very exciting. But as Anna pointed out in her presentation, the majority of children, at least in the short term, will continue to be diagnosed with clinical algorithms. We just, these new innovations are not going to be a silver bullet. And so we've really tried to sort of situate this new intervention and this new way of diagnosing TB in the context of needing a full spectrum of tools in our toolbox. So it does reiterate the importance of clinical diagnosis, and it summarizes guidance on respiratory samples, even as we try to provide some input or some information on stool-based diagnosis. Next slide. And this is just to give you an example of, we include in the guidelines a sample pathway to care that countries could adapt. And you can see that the stool collection appears twice, once in a lower level healthcare setting, and then again in the hospital setting. And again, we tried to situate it among a broader range of interventions that we need to do to ensure the highest quality diagnostic standards for children, including clinical diagnosis. Next slide. So the second thing that we're doing, and this is what we'll talk about, and then I'll just hand it over to Zambia, is we're supporting implementation of stool-based TB diagnosis in a number of countries. Most of USAID's previous experience on this is in Ethiopia and Indonesia. And we offered, in those cases, because they were pre-COVID, we had a lot of on-the-ground support for training and supervision and data collection. And based on these experiences, we've worked on these guidelines, and we're offering virtual TA for missions and NTPs who are interested in validating or piloting the use of expert. So far, we have supported pilots in Nigeria, Zambia, and Vietnam. And we are in conversations with colleagues in Mozambique, Burma, and Afghanistan to move forward in those countries in calendar year 2021. Next slide. Just to briefly touch on stool processing. So we at USAID, in these guidelines, we do focus on the simple one-step method that was developed by KNCV, and you saw a snapshot of that in Patricia's presentation. The reason that we focus on the simple one-step method is because it doesn't require additional consumables. No centrifugation is needed. It's relatively easy to train laboratory staff. And we were trying to really be consistent with the stool processing approach across countries. At the same time, we defer to the NTP's decisions regarding stool processing. So for example, in Vietnam, the NTP has made the decision they'd rather use the sucrose flotation method. And so we do spend some time on the stool processing, on the SOS method, while recognizing that there are other methods out there, and we still have more information coming on those methods through the various studies that Patricia mentioned. Next slide. Just from an M&E perspective, again, we are collecting standard indicators across our projects so that we can compare the cascades of care and identify common gaps or areas that need to be strengthened. So you can see here again, we're really situating the idea of this new or these alternative specimens in a larger cascade of care that includes a whole variety of services. And I've highlighted here in red the specific indicators that are related to stool collection. So we really want to look within the cascade of care at the type of diagnosis children are receiving, and then if they receive a bacteriological diagnosis, what type of specimen was that based on? And then we also want to look at as we expand the use of stool-based expert, we want to look at whether or not it's really contributing and whether or not we really see increased numbers of children diagnosed with TB. So this is just a brief snapshot of the types of indicators we're looking at, the disaggregations, and then some of the comments and rationale for looking at those. Next slide. So thus far, we really think that between the pilots that we've seen and the experience, even going beyond pilots in Ethiopia, that this is a very promising approach. We see a high enough yield that NTPs in general that have started to pilot it want to continue pursuing it as a rule and test. Again, in the context of ensuring that we have a wide array of services available to children, and we're utilizing all the tools in our toolkit. We know that in many places, demand creation has been a real challenge. And so we need to, at the specific country level, and even sometimes at the subnational level, we need to understand which providers are going to be most likely to take up this method and how we can best reach them. The other major sort of lesson learned is we realize that ongoing supervision is really critical, particularly in the early phases of a pilot or scale up. But so far, except with the exception again of Ethiopia and Indonesia, which took place pre-COVID, it really hasn't been possible due to COVID, or in other cases, it's just not adequately planned for. This is definitely an intervention that requires a lot of supervision, especially in the early days. Next slide. Additional lessons and challenges that we have is, again, the limitations of the COVID pandemic have made training and supervision really challenging. We have, for example, in Nigeria, they really innovatively used videos, YouTube videos, and online training. But we also noticed that in some of the supervision that was being done, what limited supervision that was being done, sometimes, for example, the SOS processing method was being done in such a way that there were concerns about infection control in the laboratories. And so we realized that we really need to try as much as possible to do the in-person where possible. Another challenge has been sort of the lack of streamlined data collection and analysis across settings. So trying to use a combination of existing data sources and adapting the existing data sources that we have in the lab registers and the treatment cards and the treatment registers, while also collecting some important sort of process level data and output level data that we need to have to understand how well the project is working. And we do have some good sample forms from Indonesia that we can share from Ethiopia that we could share as part of this, along with the presentations, if that would be helpful. The other main challenge, again, is variation in stool processing methods. And this is a challenge because obviously there are several options out there. We're still waiting on data and results from studies to figure out which one is best. But if you read some of the two systematic literature reviews that have been done on the use of stool and expert, one thing you will find is that they say it's very difficult to make some conclusions because the stool processing methods differ so much. And so, again, we really support whatever the NTP's decisions are in regards to this, but the limitation of that is that, in one country, we might be using one stool processing method, in another, it might be slightly different. Even we've seen some adaptations of SOS, which vary across countries. And so that's just been a real life challenge. And then lastly, the fast-paced sort of real-time policy changes and recommendations. As Patricia pointed out, we've seen a lot of advancement in this area of lab diagnostics in terms of studies and WHO recommendations, and we know that there's some really important ones coming. And honestly, sometimes it feels like we have, and that's all very, very good, but we almost worry sometimes that when we develop any sort of guidelines or practical guidelines for our missions and partners, they need to be updated within 2 months or something because we have new data. So we're trying to really think about how we can do some real-time adaptation of the guidelines and just be realistic about how we can get information disseminated to our partners. And then finally, just in terms of what is next, we'd really like to plan some additional pilots in USAID supported countries. We will update this interim guidance that I was just speaking about following the release of the WHO's guidelines on management of TB among children and adolescents. We're going to be providing ongoing TA to ensure that stool-based expert, again, is sort of nested within a more comprehensive package of care that includes clinical assessment. And then again, we'll be fine-tuning and sort of updating the stool processing approach as we await further study results. So I know that was really quick, but I do think it's good to just turn it over to Dr. Zimba at this point so you can hear a real life example. And I look forward to your questions at the end. Thank you.
Thank you, Drs. Hall and Coving, for the overview of laboratory-based diagnosis. Please remember that you can enter for any of our speakers into the chat box at any time during this webinar. Our final speaker is Dr. Kevin Zimba from Zambia. Dr. Zimba is a consultant pediatrician at Matero First Level Hospital in Lusaka and an honorary letter with the University of Zambia School of Medicine. He currently serves as a pediatric TB HIV coordinator for Lusaka province and childhood TB focal point for the NTP. Dr. Kevin will give more details about piloting stool-based diagnosis testing for children in Zambia. Dr. Kevin, you have the floor.
So thank you very much. We can proceed to the next slide. I hope my internet is good and you can get me. So that's just my outline of my presentation. We'll look at the rationale, validation, and the processes that we went through, and the best practices and some lessons we've learned from using Stool Expert as a mode of diagnosis of TB in children. Next slide. My internet is a bit slow, but I hope you're able to get me. The diagnosis of TB in children has especially been for a long time been said to be a difficult one to make. And so we all know that when we open several textbooks in TB, they say a diagnosis of TB in children is difficult to make. And this makes it difficult for many clinicians out there to make a diagnosis of TB. So as Zambia, we noticed that there were some parts of the country or some facilities in Zambia that were hardly ever notifying any case of TB. And this was due to lack of clinical experience to follow and confidence to make a diagnosis using the algorithm that they're going to make a clinical diagnosis of TB. So this led to the need for us to have a way of collecting a sample that is non-invasive and can easily be done by anybody out there to confirm the diagnosis of TB and do that. So we know that very well that most of our people are able to do a gastric lavage by inserting of an ANG tube. But for unknown reason, people tend not to have that confidence to do a gastric lavage in the rural setting. Sometimes we do run out of test tubes like the ANG tubes to be used in collecting the specimen. So we find that some facilities don't even send samples to the lab for from a gastric lavage for it to be done in children. Yes, the children ended up remaining behind. So this brought in the demand for an easy specimen collection and the reliable test for us to address the gap of diagnosis in childhood TB. Next slide. So we see after after this, we saw the need for us to have a test that could be easily done by everybody else out there in a simpler way. So we know very well that a gastric lavage or sputum is the best way for us to collect sputum in our children, but we're trying to find another reliable method we can use. A gastric lavage is good, but the disadvantage that it has is that most of our time our patients had to be admitted in the hospital and they relied on the need for us to have pediatric sized NG tubes, which were not easily available. Sputum induction, again, unfortunately, a sad experience. You find that in Zambia, we even had a few of our mucus extractors expire because of the low utilization in our facilities. Many people were not conversant or comfortable in doing sputum induction, so that you can end up using an nasopharyngeal aspiration and get a better yield from the gastric lavage. So the coming in of stool, once WHO, next slide, the coming in of stool, of us being able to make a diagnosis of TB using stool became, we thought Zambia could ride on this and we may help us increase the number of notifications that we're getting so that we can confirm TB, because stool was an easy sample to collect, it was non-invasive, and had a very big potential of centralizing. As you see, we managed to centralize to the entire country. Almost every facility that has a gene expert has been trained and they're able to run a stool expert test on them. And we also get to see the potential better use when we're using expert ultra compared to MTB. And I'm sure this has been highlighted by the past presenters this afternoon. Please go ahead. Next slide. My internet is a bit slow. The slides are not changing.
The current slide I'm on is stool as a rule-in test.
Okay, so as we are aware that a negative expert does not mean the patient doesn't have TB. So we had to make sure that even when we were trying to roll out the stool expert testing, that we tell the people that were and our clinicians and other community that stool is basically a rule-in test. If it comes out negative, it doesn't mean that our patient doesn't have TB. We also need to rely on other aspects that help us make a diagnosis. Our clinical acumen uses the clinical algorithms and other aspects that need to be. But we all know that sensitivity is actually quite good for the stool. I think we said it ranges from above 67%, as was demonstrated in the studies in the earlier presentation. Next slide. So what did we do in Zambia in terms of rolling out our stool expert? So we couldn't just go ahead and tell all the facilities in the country. Next slide. We couldn't just go ahead and tell all the facilities in the country that no, now go ahead and start doing a stool gene expert. We needed to validate this country and this test in country, and see that the results we're going to produce are equal or they can be reproduced several times. So once WHO had issued the guidelines and that we could use stool as one of the method samples for diagnosing TB on the expert platform. Next slide. The NTLP sat and tried to find which tests would be better to use, which method to use when validating the stool as a method of making a diagnosis of TB in children. So we reviewed the available literature and went ahead to pick the KNCV single or one-step, simple one-step method as that what Zambia would use, and this was because it was easy to do and could be performed in a similar manner as we were doing with our sputum for expert, with just minimal requirements. And we thought our aim was to make sure that every facility, even as in the far-flung areas, should be able to make a diagnosis of TB at any level, so long as we have the gene expert machine available. Hence, we picked the KNCV simple one-step method as a way of making it, as the method would use. So we validated the tests, the stool testing from 2 facilities in Lusaka. These were a tertiary hospital, Levi Mwanawasa Medical University Teaching Hospital, and at a first level hospital, which is a high volume facility, it does contribute around 8 to 13% notifications per quarter, depending in childhood TB, depending on that. So we thought it was one of the areas we could go ahead and do the validation. Next. Okay, so we did it on that. So our objective for when we're doing the validation was to see if we could get the same yield from experts too, using the KNCV SOS stool processing method, and compare it with running our standard sputum result, and to evaluate the performance of stool testing against results of experts on other respiratory samples. That was what our aim was when we're doing the validation. Next. So this slide just highlights the processes that go on through when we're using the KNCV SOS stool processing method, where we just need to collect a bit of sputum, put in a specimen, and then we mix it with the reagent, shake it and get this specimen, and put it in the cartridge, run it in the expert machine, and we get our result done. A very simple and almost a similar method is done for the sputum or gastric bad specimen that is collected from our patients. So we thought this was the best method for us to use and could easily be reproduced at all levels of care in our facility, in our facilities in Zambia. Next. So we did the validation of the stool in August 2020, and we had to compare both adult and children when doing this validation. We had about 13 cases from adults whom we validated both, and then 11 gave us a positive stool, 2 were negative. Then we got 17 who had a negative respiratory sample in adults, and the stool also gave us 17 negative results. When it came to children, unfortunately, we had very few numbers in children that were confirmed. So we only had one child who had a confirmed sputum result, and when we did the stool was also confirmed. For children, we had 12 who were negative, according to the gene expert, but when we did the stool, it was also negative. So this showed that there was a big correlation between a negative sputum and a positive sputum in correlation with the stool. So we thought this was a valid test to be done in Zambia, although we had very few children in this validation exercise that we wanted to do. And because of the time limitation and other issues, we had to move on. And this study had already been agreed on elsewhere, and WHO recommended it be done. So we just trying to validate it for Zambia. So this result gave us enough confidence to say that this test can be performed in Zambia and give us the same result that we want to expect from sputum. Next. So the next steps that we had to go now into after the validation is we disseminated the information. I think on we held an online platform through Zoom to disseminate the information in the country that the stool had been validated and to be used. After disseminating the information, we now had to roll out. So through the National TB Leprosy Program, we conducted the nationwide rollout program, which involved both provincial and facility laboratory medical scientists. So the aim was to build capacity at provincial level so that even when the NTP had left, the provincial level could go on and continue providing the technical support that is needed to the lower level facilities. And then the main hub facilities in that area that had the gene expert, at least the laboratory medical scientist was taught on how to do it. At the same time, when we were doing this, we needed to create demand for stool utilization as a method of diagnosing TB. So we did the rollout together with the clinical team. So we had the clinical mentorship program that went on together. And I must say, when we did this, we reached in far-flung areas. Some places are about 1,000 km away from the capital city, and had never diagnosed a case of TB. And from the time we took them, we took this clinical mentorship and orientation of the lab technical people, they've reported TB there. So in order for us not to lose the clinical acumen in collecting our gene experts and that people just now insist on using stool, we created a tool that we're following up to monitor how we are using the stool test countrywide from the time we rolled it out in November to today. So the aim is to measure the contribution of stool to the case detection in both children and the critically ill patients. And then the other aim of this tool is to monitor the use of gastric lavage as a gold standard specimen for children and other extrapulmonary specimens like the lymph node aspirate and others. So the idea is for our clinicians or clinical team and healthcare workers not to lose the skill that they have they need to use on the gastric lavage. Stool is not a substitute for the gastric lavage. It's just one way to help us aid make a diagnosis. So our approach for a tool was developed and circulated to all the provinces. So they populate this tool and send it back to the NTP. We're able to see it online when they do that. So there's a monthly provincial report that is submitted to the NTP, and this is discussed in our situation room that is held. Next slide. So this is just a patient algorithm that we're using. So we're saying for children 0 to 14, whom we presume to have a presumptive diagnosis, and we're unable to collect a sputum or a gastric lavage for a known reason, then we should collect a stool specimen and perform an expert. If it's positive, we initiate appropriate TB treatment. So for adults who are critically ill and can't cough, or we presume TB unconscious and everything, a stool expert can also be done on them to help confirm a diagnosis, make a diagnosis of TB. If it's negative, like I said earlier on when we started, TB stool expert is just a rule in, not a rule out. If it's negative, we need to use clinical judgment of a diagnosis of TB in our patients to find out what the differential diagnosis is. Next slide. So what is it that we saw? So with the use of the stool gene expert, we saw some areas of our country, like in Chavuma, notify cases of TB that they are not notified in a long time. So we believe this was something that was done because of rolling out of the stool expert. At the same time, the combination of when we rolled out the stool expert with a clinical team that provided clinical mentorship, and therefore we began to see a few cases of notification in areas that were never notified for children. And then we had one drug-resistant TB patient notified via stool in December 2020. Just this morning, I was sharing with the NTP manager, and he was telling me of how this child, the mother was a sputum positive patient. The child was put on TPT, developed symptoms, and then later on a stool was done, and the stool is showing detected MTB in this child that we have, and then would need to be put on treatment. So we've continued to monitor the use of the sputum and gastric lavage so that we don't lose clinical acumen in these healthcare workers that are there, that we do perform it as our gold standard for making a diagnosis of TB in children. We've continued to provide clinical mentorship and technical support and supervision to these facilities. I think right now there's some training and facilities going on countrywide to help improve these notifications. COVID has not left us this burden of rolling out the stool expert notifications in TB behind. Our notifications have not been as good as they should be, despite several interventions because of COVID. People don't come to facilities and they stay home. So it has helped us and hindered in our clinical mentorship, technical supervision that is needed. Next slide. So those are my acknowledgements I'd like to make that help and all those that participated in the validation and the rollout of those two experts countrywide. Thank you very much.
Thank you, Dr. Kevin, for the very nice presentation, also for the encouraging results. I think it's really good alternative for the very near future to increase the pediatric TB. But I would like to open the floor for the Q&A session. We will have only 5 minutes because we are almost running out of time. So please raise your hand, and I will ask for my colleague Grimania to help me in this session because I should drop off in 5 minutes.
How's the green?
I do not see any hand raised. You can also unmute yourself and ask if you cannot raise your hand in the system. There are some questions in the chat box I'm looking for. One question here, it's about from Dr. Simba Mashisha. If the stool pooled sensitivity was compared between the MTB Reef and the MTB Ultra. Up to you, Dr. Dr. Kevin, can you answer this question? If there is a comparison between MTB Reef and Ultra with the stool?
Okay, so for Zambia, we didn't compare during our validation. We didn't compare whether the MTB Reef or Ultra was going to be superior. But I think from literature, we do see that the Ultra is superior. Then there are two questions in the chat that are asking if we're using the connectivity. We do have the connectivity for the Gene Expert machine, but of late it's been down in country, so we're still working on it to try and use that to get the data for the stool that is going to be coming. So we're not using. I think that came from Patricia. If we're using the connectivity for the gene, so it's been down of late. But we are still working on it, and we hope it's done shortly. So what we're now using is just that tool that our facilities and TB focal persons populated and are able to do that. Then there's another question from Barbara on the child with the DRTB. If the mother had DRTB, I would have to check that. I don't have that information offhand. I would have to check that and counter check. Thank you.
Okay, no, thank you. I do not see any hands raised. If we do not have anyone requesting to make questions or comments, I will suggest to give the floor to my colleague Crimenia to make the closing remarks. We still have 3 minutes, but I do not see any question.
Barry, there's 2 questions in the chat box, I think, for Kevin. Your presentation's been very popular. Maybe if it helps, I can read them out. So there's a question from Anna, said, did healthcare workers dislike the idea of using stool as a specimen, and how about parents? And then there's another question from Maureen Siddique on were the children able to provide a sample on the same day? And again, a bit like Anna's question, what was the attitude of the lab teams? Sorry, those were in the chat. I know it's hard for everyone to see all of those.
Please, Dr. Kevin.
Okay, so thank you. So I think what was key was that from the word go, the push to use stool was now driven by the lab focal person. I think Winnie Mwanza was the one who was helping us push the use of the stool in the laboratory. So she had engaged the laboratory staff, even from the word go. So there was no, they didn't dislike the idea of collecting, of running the Gene Expert using stool. So initially, when you explained to them, it was a bit, oh wow, how are we going to do it? But when she explained the process, they bought into the idea and could see. And then the fact that it was just maybe 1 or 2 extra steps from the traditional stool, sputum that was being done. It was not that, but so they thought it wasn't extra work and was easily acceptable. Because I think when she did the orientations, within 30 minutes, the orientations were done, and we spent the rest of the time, or like during the route. And then she's done the orientation. When we're doing the validation, she done the orientation, and people okay. We're now in the lab trying to see them perform the test. Then for specimen, for some children, we're able to give us sputum there and then. For others, we had to wait for the sputum even the following day for them to give us the sputum. For some patients, like right now, for some patients, we're even able to give them the container. They go home and bring the specimen later on, like any morning specimen, and they bring it then and even admit them. Then we're able to follow them up within 3-4 hours. The result is out. Thank you. I hope I've answered this.
Thank you, Dr. Zimba. I think we have more questions at the chat box. The first one is from Charles. I think it's for Daughters Hall and Coving. Charles is asking if tuberculin skin test and gastroalveolar lavage aspirates can they play an impactful role in childhood TB diagnosis? Please, Dr. Hall and Coving.
Yes, thanks, and thanks for the question. So TSTs or tuberculin skin tests are recommended for detection of TB infection and can be used for determining exposure, so childhood exposure to TB, but are not currently recommended for active TB diagnosis. So a little bit of a separation there compared to, for example, the diagnostic tests such as TB Expert or the TrueNat assays. And then to my knowledge, and I apologize, I'm a microbiologist and not a clinician, but to my knowledge, the lavages, the gastric lavages may not be perform as well on our molecular diagnostic tests as the gastric aspirates. And I would ask any other colleagues on the line that have experience with that to maybe weigh in. I've seen some publications over the years that suggest that perhaps lavages don't seem to capture as many bacilli for whatever reason as the aspirates. And of course they remain in basin. Over.
Thank you. We have more questions about the slide on the presentation of Dr. Paul and Kelvin. In the pathway to case slide, there seems to be no box for clinical diagnosis at the lower level healthcare setting. Isn't there a place for clinical diagnosis and TB treatment initiation at the lower level healthcare setting? Dr. Hall and Kevin, please.
Sorry, I didn't get the question clearly. I'm trying to find it in the chat. I can't see it.
I believe that might have been a question for me about the clinical assessment. And yes, I'm sorry, I went through that slide pretty quickly, but you'll see when we send the slides out that there is a part in the pathway to care for clinical assessment and diagnosis at the lower level healthcare facility. I'm sorry, I went through that pretty quickly. Yeah. And I also, can I just go ahead and answer another question I saw while I'm unmuted? Dr. Matemba, is that okay? So,
yes, 1 minute, please.
Okay, so Dr. Yara Tedesse asked a question about transporting stool samples from non-expert to facilities with expert. And I just wanted to say that, yes, that is possible. And that's one thing that we're looking very closely at as we scale up. And KNCV is doing some interesting research now on the use of different storage media and storage conditions. So they're looking, for example, if they keep the stool for 2 days versus 4 days versus 6 days, and like the actual specimen amounts. They're doing a lot of testing on that. I believe it's in Ethiopia. And hopefully in the coming months, we'll have some good data that will help inform the storage and transport conditions that are most optimal for taking a stool specimen from a non-expert to an expert site. So I'd be happy, you may or may not know Evelyn Klinkenberg. She's been working on that, and I'm sure she could tell you more about that if you're interested, Dr. Tedesse.
Thank you. We are out of time, and I think we have no more questions. We hope this discussion has been helpful and highlighted the advances in this field and will help guide our members on how to incorporate novel techniques for diagnosing TB in children with long-standing gold standard methods. More detailed guidance alongside operational consideration is likely to follow later in the year as WHO release updates guidelines on managing child and adolescent TB. I'd now like to welcome co-chair of the Center of Excellence to say a few words in closing remark. Thank you.
Thank you so much, Dr. Mutemba. I'd like to thank all our speakers today for sharing their expertise and all the participants for really joining us today for this very engaging and thoughtful discussion. I'm hopeful that we will continue to share evidence-based methods for clinical diagnosis, but also share neo-diagnostic technologies and methods for acquiring both respiratory and non-respiratory samples. We believe that with this kind of information sharing and webinars, we'll be able to contribute effectively to the national child and adolescent TB responses at all levels within our member countries, but also be able to support in finding more children and adolescents with TB and also strengthen the quality of TB services within our member countries. So we look forward as the COE to continue sharing and working together to share as much information as possible. And then finally, I'd like to thank Drs. Barreira, Dr. Mutemba, Dr. Mandalakas, Dr. Hall, Dr. Coving, and Dr. Zimba for your excellent presentations today. And to all our participants, we will receive a follow-up email within the coming few days with a survey of this session. And would really appreciate so much if you'd complete this survey to provide us enough feedback on this webinar, but also enable us to continue to improve and refine our webinar series. We'll also share the recording as already shared in the chat box, and we'll also share a link to the recording of today's webinar. So on behalf of the union and our partners at CDC and our presenters, thank you all for joining us today and enjoy the rest of the day. Bye.